Okay, hi everyone, to the best course of USMLE Step 1, starting with the psychiatry. Let's go. Classical conditioning. Learning in which a natural response as salivation is elicited by a conditioned or learning stimulus as a bell that previously was presented in conjunction with an unconditioned stimulus as food. Usually elicits involuntary response. Pavlov's classical experiments with dogs ringing the bell provoked salivation. So they're gonna ask you, they're gonna give you an example like a patient that is used to go into the doctor when she was young, and it made her anxious, and now she's living with a roommate that is a nurse, and whenever she sees the stethoscope of the roommate, she gets anxious. So this is classical conditioning. Operant conditioning, learning in which a particular action is elicited because it produces a punishment or a reward, usually elicits voluntary responses. So this is voluntary. We have two operant conditioning, reinforcement and punishment. Reinforcement is target behavior, response is followed by desired reward. So the target behavior or response is positive reinforcement or removal of aversive stimulus. Negative reinforcement. Okay, punishment, repeated application of aversive stimuli, positive punishment or removal of desired reward. Negative punishment. To extinguish unwanted behavior. So there are things that increase the behavior and things that decrease the behavior. The increase and decrease we can use usually the reinforcement is used for increasing the behavior. So positive reinforcement is giving a reward. Okay. And negative reinforcement is removing something bad. Okay. So these two things would would help increase the behavior. And this is adding stimulus and this is removing stimulus. Negative is removing the stimulus. Okay. The positive and negative punishment. Positive, so adding stimulus is giving the punishment, you decrease the behavior, and negative punishment is that by removing a desired, something like removal of desired reward. So that's a negative punishment. You punish him, but in a negative way, removal of a desired reward. Skinner operant conditioning quadrant. This is the Skinner or whatever. Discontinuation of reinforcement, positive or negative, eventually eliminates behavior, can occur in operant or classical conditioning. So extension can occur in operant or classical by stopping the motivator, the reinforcement, eliminating that behavior. Okay. Then transference and counter-transference. Transference, patient projects feelings about formative or other important persons onto the physician. So transference is the patient onto the physician. Counter-transference is the physician onto the patient. Okay, so for example, they'll tell you that a patient came to the hospital and while talking to his doctor, he was like acting like when the doctor asked him what's the problem, he just replied like, I know you want me to be perfect like all the other patients and that. So he will remember his father while talking to the patient, okay, to the psychiatrist or to the doctor. The patient will remember, for example, his father while talking to the doctor. But counter-transfer, the physician will remember, for example, her younger sibling or his son while talking to the patient. Ego defenses, we have immature and mature. The immature, let's just talk about the important thoughts and behaviors, voluntary or involuntary, used to resolve conflict and prevent undesirable feeling. So the most important thing about the ego defenses is that they are prevent undesirable feelings. Okay. Acting out is subconsciously coping with a stressor or emotional conflict using actions rather than reflection or feelings. For example, a patient skips a therapy appointment after deep discomfort from dealing with his past. So he doesn't want to deal with his past. That's an undesirable feeling, that the past. He doesn't want to deal with the past, so he will act out by skipping therapy. Another example is that patient is going through divorce. So instead of like going through it, he would just vandalize or ruin his wife's car. This is another example of acting out. Denial, avoiding the awareness of some painful reality. A patient with cancer plans a full-time work schedule despite being unwarned of significant fatigue during chemotherapy. So he just denies the fact that he has cancer and will have fatigue during chemotherapy and just will plan a full-time work. Displays introduction of emotions or impulses to a neutral person or object. After being reprimanded by her principal, a frustrated teacher returns home and criticizes her wife's cooking instead of confronting principal directly. So yeah. Another example is that, for example, someone is going through a divorce. So instead of going through it, he would go to work and let's say he works as a cashier. He would start to deny the customers, like deny their they want to return something, so they will deny it. And yeah, this is displacement. Dissociation, temporarily, drastic change in personality, memory, consciousness, or motor behavior to avoid emotional stress. Patient has incomplete or no memory of traumatic events. A survivor of sexual abuse sees the abuser suddenly becomes number detached. Yeah, this is dissociation. Yeah, another example is that they will ask you that a patient is doesn't remember a specific or goes numb, yeah, goes numb and detached while when they see the abuser, and this is the dissociation. Fixation, partially remaining at a more childish level of development versus regression. A college student continues to suck her thumb when studying for a stressful exam. Okay, what about regression? Implemented turning back to the maturational clock to behaviors previously demonstrated versus under stress. A previously trained child becomes bedridden again following the birth of sibling. So this is the stress. Under stress birth of the sibling who start bedwetting, going back to the... I don't know, I can't see any difference between them. But in the U word, an example about regression is that someone is going through an appointment that gets her stress, and she would sleep with her teddy bear. So this is a regression. Fixation is a college student continues to suck a thumb when studying for a stressful exam. Okay. There isn't a lot of examples about fixation in the board, but regression we have like some, like for example, a patient is scared, so about being alone or something, so he'll go sleep in his parents' room. This is one example. Another example is that, as we said, sleeping with a stuffed animal because of an anxiety for an upcoming appointment. And yeah, idealization is expressing extremely positive thoughts of self and others while ignoring negative thoughts. So yeah, looking at the positive only is idealization. A patient boasts about his physician and his accomplishments while ignoring any flaws. Identification, largely unconscious assumption of the characteristics, qualities, or traits of another person or group. A restraint starts putting her stethoscope in her pocket like her favorite attendant, instead of wearing it around her neck like before. So this is identification, taking like some of the characteristic qualities and traits of another person. Intellectualization, using facts and logic to emotionally distance oneself from a stressful situation. A patient diagnosed with cancer discusses the pathophysiology of the disease. This is intellectualization. Okay. Isolation, passive aggression, isolation of affect, separating feelings from ideas and events. Describing murder in a graphic, yeah, so this is in a graphic with no emotional response, so this is isolation. Passive aggression, demonstrating hostile feelings in a non-confrontational manner, showing indirect opposition. So, example, a disgruntled employee is repeatedly late to work but won't admit it. It's a way to get back at the manager. Yeah, another example is that the doctor was late for the appointment, and the patient, instead of the patient was given a history form to fill it while the doctor was on his way. So the patient didn't fill it, and I would reply to the doctor like, "You're a doctor, you're supposed to take the history." That's a passive aggression. Projection, attributing an unacceptable internal impulse to an external source. Displacement, a man who wants to cheat on his wife accuses his wife of being unfaithful. Okay, so another example is that a patient is angry at his wife because she's divorcing him, and instead of admitting that he's angry, he would just say that she's the one that is angry at me. Rationalization, asserting plausible explanation for events that actually occurred for other reasons, usually to avoid self-blame. An employee who was recently fired claims that the job was not important anyway. The job was actually important, but he just did that explanation to avoid self-blame. Another example is that a patient is working as a cashier and he was going through a divorce. He started treating the customers bad. So instead of just admitting that he's mad because of the divorce, he would just say, "Oh, the customers are bad and they deserve to be treated that way." Reaction formation is replacing a worded off idea or feeling with an emphasis on its opposite versus sublimation. A stepfather treats a child he resents with excessive nurturing, and overprotection. So actually, the stepfather resents this child. Instead of treating him in a bad way as his feelings, he would do the opposite. Another example is that a patient is mad at his wife because she's going through a divorce. So instead of acting the way he feels, he would start to act as loving or start being nice. There are a lot of examples. Let's go to regression. Involuntary turning back to the maturational clock. Turning back the maturational clock to behaviors previously demonstrated under stress versus fixation. A previously toilet trained child begins bedwetting again following the birth of a sibling. So yeah. Another example is this is a good example actually. Another example would be a patient that started sleeping with her stuffed animal because of an anxiety of upcoming appointment. Repression, involuntary withholding an idea or feeling from conscious awareness versus suppression. At 20 years old, does not remember going to counseling during his parents' divorce 10 years earlier. Okay, repression. Let's see the suppression. Let's see the different intentionally withholding an idea or feeling from conscious awareness versus repression temporarily. An athlete focuses on other tasks to prevent worrying about an important upcoming match. Okay. I guess repression also was someone was sexually harassed or something, so they would unconsciously forget what happened. Okay, splitting, believing that people are all either good or bad at different times, but due to intolerance of ambiguity. Common in borderline personality disorder borders splits countries. A patient says that the nurses are cold and insensitive, but the physicians are warm and friendly. Oh wow, this is an example of racist people. Like, example, someone was treated bad by a Mexican or something. So he starts saying that all Mexicans are bad and yeah. So splitting is like it's all good or bad. Okay, another example of splitting is that a patient was going through a surgery and the surgery went well, so he was like, "Oh, this surgeon is brilliant," and then the in the follow up, the surgeon was late due to another surgery. Then he will start like saying the opposite, like all surgeons are bad, and so that's splitting. Then we start. Let's go to the mature defenses. These things are mature. Defenses. Sublimation first one, replacing an unacceptable wish with a course of action that is similar to the wish but socially acceptable versus reaction formation. For example, a teenager's aggression towards her parents because of their high expectation is channeled into excelling in sports. So this is sublimation. Someone is going through an undesirable feeling, okay, which was here the high expectations of the parents. So they, in sublimation, they replace this feeling with an action that is socially acceptable. So here, high expectation is channeled into excelling in sports. Okay, another thing is the sublimation. Someone is going through stress or something, so he will start going to the gym, or he will go boxing or whatever. So these are examples of sublimation. Altruism, alleviating negative feelings versus unsolicited generosity, which provides gratification versus action formation. A mafia boss makes a large donation to charity. So altruism is the generosity. Okay. Suppression, intentionally withholding an idea or feeling from conscious awareness versus repression. This is temporarily. Okay. An athlete focuses on other tasks to prevent worrying about an important upcoming match. This is a healthy way. So another example is someone that just took their step 1 exam, and instead of worrying about the result, they will do other things. They will focus on other things. Okay. Humor, lightheartedly expressing uncomfortable feelings to shift the internal focus away from the disasters. A nervous medical student jokes about the boards. And the mnemonic for the mature defenses is mature adults wear sash. Okay, mature adults wear sash. Let's go to sash for sublimation, altruism, suppression, humor. Sublimation is doing another things that is socially acceptable. Altruism is the generosity. Suppression is focusing on other tasks to prevent worrying. Let's see repression. This is like forgetting. Oh, that's why they said this is temporary. But this is, they don't remember. So this is not temporary. Humor is not grief. Natural feeling that occurs in response to the death of a loved one. Symptoms and trajectory vary for each individual, are specific to each loss, and do not follow a fixed series of stages. In addition to guilt, sadness, and yearning, patients may experience somatic symptoms as hallucination of the deceased or transient episode of wishing they had died with or instead of their loved ones. Typical acute grief is time-limited. Adaptation within 6 months and is not a disorder. Typical acute grief is time-limited and the adaptation within 6 months, and it is not a disorder. But prolonged grief, diagnosed if grief remains intense, persistent, and prolonged at least 6 to 12 months. Okay, significantly impaired functioning and is inconsistent with patient's cultural or religious norm and do not meet criteria for another disorder. Okay, even though the normal grief will have guilt, sadness, yawning, patient somatic symptoms, hallucination, disease, and every that, but it is normal until 6 months. Well, after 6 months, that's when it becomes prolonged grief disorder and doesn't meet the criteria for another disorder as major depressive disorder. Okay, let's go to the normal infant and child development. Okay, now let's go to the normal infant and child development. Milestone dates are ranges that have been approximated and vary by source. Children not meeting milestones may need assessment for potential developmental delay. Let's see how can we remember these milestones. Starting with the age infants from 0 to 12 months, that's 1 year. Primitive reflexes disappear, which are the motor rooting, and we have the suckling, plantar, which is the Papinski, and the gallant, and Mr. Peanut Butter. Okay, the P in parents, motor. Parents. So maybe the parents start observing. Okay, infants. So the parents start observing. Toddler, the child reading, working. Preschool, don't forget they are still learning. Okay, nice mnemonics. So the infant is parents start observing. Parents, the P in parents will be for the primitive reflexes, the posture, the picks, and points to object. So primitive reflexes, we already discussed them. Now let's go to the posture. Posture, left head up, prone. So I remember the posture by 1 month. Okay, so the head, this is the baby. This is the baby, and this is the head. Okay, so the head is the baby is like number one. Okay, posture, left head by 1 month, rolls and sits by 6. So this is a chair. Okay, and the baby sits on the chair by 6. So this is how he sits by 6. Crawls by 8. I remember the 8 is like a track. So he's crawling in circles. Crawls by 8, stands by 10, as if this is the baby and he's standing. Okay, the baby standing, and this is like the wound next to him, or a stick that he holds. So stands by 10, walks by 18. We said crawling 8. So with the stick, he's walking. Okay, so walking without crawling, without the 8. So this is 10. Only walking, only standing, and this is walking. Picks, passes toys, hands to hand, 6. So yeah, he's sitting and giving the toys, passing toys by 6. Pincer grasp by 10. Pincer grasp by 10. Yeah, so let's imagine this is the hand, and this is the thumb. These are the fingers. So he's pincer grasping, he's catching. So it will be 0 and 1, 10. Pincer grasp by 10. Yeah, see? Pincer grasp. This is the 0 and this is the 1. Okay. What else? Points to objects by 12. Okay, points to objects by 12. Social. We said 6 is like giving the passes the toys. Okay, and if there are 2 6 like 12, that's to be pointing to objects. Okay. Now let's go to the start. We can start observing. Start for the S as 3. 3 things for start. S for the social smile. Social smile by 2. 1, 2 lines gives you a smile. Stranger anxiety by 6. We said 6 is sits and passes and pushes away strangers. Okay, sits in the chair and passes toys hand to hand and pushing away stranger and anxiety. Let's say stranger is here, so they are inches, so they go this way. And separation and anxiety. Okay, I remember it like 69 is like an anxiety. So 9 is separation and 6 for the stranger. Okay. Observing, start observing. O for orients, first to voice by 4 months, then to name and gestures. So orients, voice, name, gestures. Object permanence by 9. Oratory says mama and dada by 10. We said 10 is standing, so he stands and says mama and dada. Object permanence by 9. Orients first to voice by 4, then to name and gestures by 9. Toddler, child, takes first step by 12, climbs stairs by 18, cubes stacked number 3 each year multiplied by 3. So cruises takes the first step by 12. Okay, we said 10 he's standing, 18 he's walking, so this 12 will be first steps. Climb stairs by 18. We already said 18 is walking and would be also climbing stairs. Okay, let's just imagine that is 18 is like that, 8 and another 8 and another one here, so these are the stairs. 18 stairs. And cubes stacked number, age, cubes stacked number, age period multiplied by 3. Okay, this is the number of cubes that they can stack. So let's say he's 1 year, they can stack 3 cubes. Second year, 6 cubes. Poultry feeds self with fork and spoon by 12. Okay, so they feed themselves by 20, I mean. Feed self with fork and spoon. These are fine motor by 20. Okay, kicks ball by 24. So we said 4 is for voices. 24 is 2 years. Kicks the ball, 24. Child reading, working, recreation, parallel play by recreation, parallel play. Okay. Okay, poultry feeds self with fork. Let's imagine that this is a plate and this is a spoon. Okay, how is it a spoon? If you turn the two this way, it will be like that. So here you put the food, so it's like a spoon, and you hold it from here, so it's like a spoon. 20. Kicks ball, 24. Reaction, parallel play, reading, recreation, parallel play by 24, 36. Let's see what's parallel play. Okay, this is it. By 24, 2 years and 2 years and a half. No, 3 years. So 2 years to 3 years, they will parallel play. Let's remember that the parallel play, it has like 2 to 3 shapes. Square and that rectangular side, it's like 2 to 3 shapes. Rapprochement moves away from and returns to parent. Rapprochement, so this is 24, 2 years. Let's imagine like one parent to the other, they will go to this and this is 2 years. Realization, core gender identity formed by 3 years. Okay, core gender identity formed by 3 years. Let's remember that gender, they always say like male, female, or something else. They prefer not to say or whatever, so they are 3. So 3 years gender. Working, words uses 50 to 200 words by second year. Okay, so second year, first year we said the first year would be saying mama, dada. Okay, second year will be 50 to 200. Okay, that's easy. So 2, second year 200, third year 300, fourth year would be understands 1,000, complete sentences and prepositions by the fourth year, and can say detailed story. Okay, that's easy. So let's go over it again fast. Okay, so cruises and takes first steps by 12. We said, as we said, the 18 is walking, 10 is standing, so between them is like the first step, so that's 12. Climb stairs, we said 18, that's 8, it's like a stair. 18 stairs. Cubes tagged, so cubes is multiplied by 3. The age, poultry feeds themselves by 20. We said that's a plate, and this is a spoon and a fork too. Let's imagine like it's written like that, 20. So a spoon and a fork. Spoon, so you put the foot here and the fork. Okay, by 20. Kicks the ball, 24. So yeah, let's imagine that this is the 4. This is the 4 and kicks. Other recreation, parallel play. Parallel play, there are 2 to 3 figures, so or shapes, so it's 2 to 3 years. Rapprochement, going from mother to the father and going back, that's from 1 to 1, that's 2 years. Realization, gender 1, 2, 3, 3 years. Words, 2 words. Second year, 200. Third year, 300. Drive, tricycle. 3 years, 3. 3 wheels at 3. This is so easy. 3 years at 3. Drawing, copies lines or circles, stick figures by 4. Figures by 4, stick figure by 4 years. Let's remember that stick figure is made by 2 lines. By 4 lines. 1, 2, 3, 4. Okay. And copies line or circle. Circle, 1, 2, 3, 4 quarters, and line. Stick figure by 4. Dexter hops on 1 foot by 4. Let's imagine that this is the baby and this is 1 foot. This is his hand and this is hopping in 1 foot. So this is 4. 4 on foot, 1 foot, 4 on 1 foot, 4 on 1 foot. That's a good mnemonic. Uses buttons and zippers, grooms self by 5. Okay. Freedom, comfortably spends part of day away from the parent by 3. We said going back and forth to the parents by 2. So if he went away, that's a third direction. So going away by 3. Oh, that's a good one. Friends, cooperative play has imaginary friends. So away from parents, that's 3. Away from 2 friends, that's 4. Okay, that's good. Language. Language understands 1,000 words by 3. So yeah, 1,000 has 3 zeros. So okay, that's 3 years. Uses complete sentences and prepositions by 4. We said 3 was 300. 4, it's not like 400. 4 would be like saying complete sentences, prepositions. Okay, legends can tell detailed stories. So that's a good mnemonic. Legends can tell stories. This is another way of saying them. So 3, we said walking upstairs, alternating feet. Alright, tricycle, we already said that one. Walking upstairs, alternating feet. We said upstairs was 18. Okay. 1 foot was 4. Upstairs 1 foot was 4. Oh, okay, alternating feet. So, okay, upstairs, alternating feet, that's 3 years, so 36. Okay, whatever. Dresses with help uses fork. Copy circle. We said that fork was using fork and spoon was 20. Oh, well, they are different. First age is different from the word. Okay. Says more than 3 word sentence. Speech. No, 6. Age, yeah, we said this one. Age and 6. Plays with children. From parents. Away from parents. Okay, let's say plays with children. Plays with friends. We said 4 years. Okay. Maybe they meant 3 and above. Maybe they meant here 3 years and above. Okay, says... Okay, first year we pull to stand. We said that. Cruises, pincer grasp. We said that pincer grasp was 6, I guess. 6 months. By 10. Oh yeah, we said pincer grabs. They'll catch it with both the index and the thumb. They'll catch something, and the rest of the fingers will be like that. So this is 0 and this is 10. Okay, pincer grasp is 10. Says mama and dada. First year, okay, understands no, okay, please, bat, cake. Okay, looks for hidden objects. 15, takes a few steps, stacks 2 blocks. Says 1 or 2 words. Follows first step command with gestures. Points to something, shows affection. Yeah, we said points to something. That was 6 and 6, so that's 12. For this one's 18 months, walks easily, climbs off on chair. Okay, we said walking, standing was 8, it was 10. Walking was 12. 18 was upstairs, right? 1 month, stands by 10, walking by 12 to 18, and 18 was climbing stairs, exactly. No, 6 by 3, or okay, says more than 50, uses spoons by 2 years, so uses spoons by 2 years, we said spoon and fork by 20 month. Says to, whatever, let's just skip it and go to the next page. Child abuse. All cases of suspected child abuse must be reported to local child protective services. Neglect. This is the first way or method of child abuse. The signs of this abuse is you'll see that the child has poor hygiene, malnutrition, withdrawn affect, impaired social emotional development, failure to thrive due to failure to provide a child with adequate food, shelter, supervision, education, or affection, Epidemiology: most common form of a child maltreatment is the neglect. Physical abuse, non-accidental trauma, as fracture, bruises, burns, injuries, often in different stages of healing. Or yeah, this is a very characteristic expression or the presentation. The injuries in different stages of healing or in pattern resembling possible implements of injury includes abusive head trauma, shaken baby syndrome, characteristic by subdural hematoma or retinal hemorrhages. So retinal hemorrhages in the baby or subdural hematoma is a sign of child abuse. That's a physical abuse. Caregivers may delay seeking medical attention for the child or provide explanations inconsistent with the child's developmental stage of pattern of injury. Yeah, so they will come like 2 days after the injury, or they will give a weird story. 40% of death related to child abuse or neglect occur in children less than 1 year. Sexual abuse, that's STI, sexually transmitted infections or urinary tract infections, and genital, anal, or oral trauma. Most often, there are no physical signs. Sexual abuse should not be excluded from a differential diagnosis in the absence of physical trauma. Children often exhibit sexual knowledge or behavior incongruent with their age. Peak incidence of sexual abuse is from 9 to 12 years old. Oh God. Okay, so a sign of sexual abuse is that the children will exhibit sexual knowledge or behavior incongruent with their age. So there is absence of physical trauma sometimes. Okay, emotional abuse. Babies or young children may lack a bond with the caregiver but are overly affectionate with less familiar adults. They may be aggressive towards children and animals or unusually anxious. Okay, so aggression towards children and animals or unusually anxious is a sign of emotional abuse, and they lack a bond with the caregiver. And they will develop this bond with someone else. Older children are often emotionally labile and prone to angry outbursts. They may distance themselves from the caregiver and other children. They can experience vague somatic symptoms for which a medical causes cannot be found. So yeah, somatic syndrome or somatic symptoms can be in children suffering from emotional abuse. Okay. 80% of young adult victims of child emotional abuse meet the criteria for more than one psychiatric illness by age 21. Vulnerable child syndrome. Patients perceive the child as especially susceptible to illness or injury versus factitious disorder imposed on another. Usually follows a serious illness or life-threatening event, can result in missed school or overuse of medical services. They ask sometimes about this question. Oh, let's go to the next page. The attention deficit hyperactivity disorder, onset before age 12, but diagnosis can only be established after age 4. So it starts before 12 and diagnosis after 4. Characterized by hyperactivity, impulsivity, and or inattention. Hyperactivity, impulsivity, and attention for more than 2 seconds in school. This is very important. Normal intelligence but commonly coexists with difficulties in school. Often resistant adult commonly coexists with other behavior, cognitive or developmental disorders. Treatment stimulants as methyl-phenidate, behavioral therapy, and to include atomicity. Okay, atomicity. So the case will be a patient that is that is disturbing the class in school, is not attentive, and at home he's not listening to the parents. And so at school and at home, they might ask you like parents came to the office and they are complaining that their children is not listening to them, the mother and the father, and you ask you like what should be the next question should you ask, and it will be like a teacher should be another thing. They'll ask you that a patient having ADHD and he wants another drug not a stimulant because he has a brother that is suffering from that has a history of substance use disorder. So instead of giving a stimulant, you will give atomicity, which is an androgen, and after 2 agonists, clonidine and guanfacine. ADHD has nothing else that is important. Autism spectrum disorder, alien childhood, social and communication deficits, repetitive visualization behavior. This is very important. Repetitive visualization behaviors. For example, the patient likes to sit in the same seat in school. He likes to do repeated actions. Restricted interests may be accompanied by intellectual disability or above average abilities in specific skills as music. Yeah, the patient would be very interested in numbers and very hard to shift the topic from the numbers. More commonly means associated increased head and brain size. Conduct disorders, repetitive pervasive behavior violating social norms or the basic rights of other aggression towards people and animals. Destruction of properties, theft after age 18, often be classified as antisocial personality disorders. Conduct children, antisocial adults, treatment psychotherapy, cognitive behavior therapy. Repetitive pervasive behavior violating social norms or basic rights of others. This is very important. Basic rights of others. So for example, they will say a patient that is angry at the after conduct children antisocial psychotherapy, violating social norms. So he will burn the school lockers and he will steal his friends' pencils or whatever, and he doesn't feel guilty and he will blame them that they are stupid, that they are not careful with it. Disruptive mood dysregulation, often before age 10, severe recurrent temporary outbursts out of proportion to the situation. Child is constantly angry, irritable between outbursts. So irritable between outbursts. Treatment is CBT, stimulants, antipsychotics. Intellectual disability, global cognitive deficit, specific learning disorder. That affect reasoning, memory, abstract thinking, judgment, language learning. Adaptive function is impaired, leading to major difficulties with education, employment, communication, socialization, independence. Treatment psychotherapy, occupational therapy, social education, special education. Okay. So yeah, they'll tell you that patient is doing good with everything, but he has a specific learning difficulty result in one thing. Okay. Intermittent explosive disorder, onset age after age 6. recurrent verbal and physical outbursts presenting the failure to control aggressive impulses, outbursts less than 50 minutes and are out of proportion to provocation and may lead to legal, financial, social, consequences episodes are not humiliated and may provide an immediate sense of relief followed by remorse. This is very important. Sense of relief followed by remorse. So they present a case that a man is arguing, goes crazy on his girlfriend, and he feels relief after the outburst, but then feels bad and feels remorse. Psychotherapy and SSRI. Oppositional defiant disorder, patient pattern of anger, irritability, argumentative, vindictive, and defiant behavior towards authority figures lasting for more than 6 months. Treatment is psychotherapy, CBT, lasting for more than 6 months. So that is, they will tell you like a patient that is always arguing with authority figures like the teacher, he doesn't study well, and they will tell you that the school rules are stupid, and that's oppositional defiant. For monism himself, mutism, onset before age 5, anxiety disorder, lasting for more than 1 month, involving refraining from speech in certain situations despite speaking with others, usually more comfortable situation, development, speech and language not typically impaired, interference with social, academic, and education, task commonly coexist with social anxiety disorder, treatment, behavior, family, play therapy, SSRI. Okay. Separation anxiety disorder, overwhelming fear of separation from home or attachment figure, lasting for more than 4 weeks. 4 weeks separation anxiety, 4 weeks. Can be normal behavior up to age 3 to 4. May lead to factitious physical complaints to avoid school treatment, CBT, play therapy, family therapy. So they will tell you, like, for example, a patient that feels sick whenever she goes to school and she skips school. She feels nausea whenever she goes to the party with her friends. She wants to go home. She has nightmares of her parents being sick. This is separation anxiety. Specific learning disorders, onset during school age, inability to acquire or use information from specific subjects, for example, math, reading, writing near age expected proficiency for more than 6 months, despite focused intervention, general functioning and intelligence are normal versus intellectual disability. Treatment, academic support, counseling, extra curricular activity. So this is, you can't acquire all these information, specific subject like math, writing, whatever, for more than 6 months. So specific learning is more than six months, okay? Okay. General function, Tourette syndrome, or onset before age 18, sudden recurrent non-rhythmic stereotype motor as grimacing, shrugging shoulders, and vocal grunting, throat cleaning, motor, and vocal. Tics that persist for more than 1 year. Tics that persist for more than 1 year. Coprolalia, involuntary absent speech found in some patients associated with OCD and ADHD. Treatment is psychoeducation, behavioral therapy for intractable and distressing tics. Tetrabenazine, antipsychotics, alpha-2 agonist. Okay, they will tell you, for example, a patient that is constantly disrupting school and making weird noises, clearing his throat, and he's shrugging his shoulders, and that's why he has Tourette syndrome. Orientation, patient's ability to know the date and time when they are and who they are. Holder of loss, time, place, person. Okay. Common cause of loss of orientation is alcohol, drugs, fluid, electrolyte imbalance, trauma, hypoglycemia, infection, nutritional deficiency, psychosis. Amnesia, we have retrograde and anterograde virtue, inability to remember things that occurred before, as seen as insult. Antegrade, inability to remember things that occurred after, seen as insult. Anti, after. So decreased acquisition of human Korsakoff syndrome, amnesia, antegrade more than retrograde, disorientation, caused by vitamin B1 deficiency associated with disruption of the system, especially the memory bodies and anti-thalamus. Seen in chronic alcohol use and later neuropsychiatric manifestations of phonics and telepathy. Confabulation characteristics. So confabulation is making up new memories because you can't remember. So making up stories. Okay, dissociative disorders, we have depersonalization, derealization disorder, resistant feeling of detachment or estrangement from one's own body, thoughts, perceptions and actions, depersonalizations, and one's environment, derealization, intact reality testing versus psychosis. So they'll tell you that a patient was suffering from, like, she zones out, and after her boyfriend's breakup, she has been feeling like she's something that is happening to her body as if it's happening to someone else, and she's not aware of the surroundings. So this is depersonalization disorder. Dissociative mania, inability to recall important persons, inability to recall important personal information, usually following severe trauma or stress, may be complicated, accompanied by dissociative fugue, okay, abrupt, unexpected traveling away from home. Okay. For example, they'll tell you that a patient that was saving her sister from drowning, she drowned, and then she can't remember anything about the incident and gets anxious whenever she's asked. This is dissociative amnesia. Dissociative identity disorders formed multiple personality disorder. Okay, presence of more than 2 distinct identities or personality states. Typically with distant memories and patterns of behavior, more common in infants associated with the history of sexual abuse, PTSD, depression, substance use, body language disorders. So it has a history of everything. Delirium marks the level of consciousness with acute onset, decreased attention span, decreased level of arousal, characterized by disorganized thinking, hallucinations, often visual, misperception, illusions, distance, and sleep cycle, cognitive diffusion, dysfunction, agitation, reversible, usually secondary to other identifiable illnesses seen as disease, infection, trauma, substance use, withdrawal, metabolic drug disturbance, hemorrhage, urinary or fecal retention, or medications, anticholinergics, especially in older adults. Most common presentation of altered mental status in inpatient settings, especially in the ICU. Exactly. And during prolonged hospital, so they tell you that patient was transferred to the hospital, and in the first day, after the first day, he was disoriented, started being a bit anxious and aggressive. So delirium changes in sensorium. ECG may show diffuse background breath, slow treatment, identification, management of underlying condition. Yeah, they'll tell you that patient was normal and going through dialysis. A patient was normal and going through dialysis, and after 1 day, she became uncooperative, and she had the nurse with her hand without meaning to, and her temperature was high, so maybe she had pneumonia and delirium. Orientation, treatment, identification, management of underlying condition, orientation protocols, keeping a clock or calendar nearby, decrease sleep disturbance. This is very important. So they'll tell you, for example, the patient was having delirium at the same scenario, and they will tell you what can we do to help him. They will increase the sleep or something like decrease sleep disturbance. And increase cognitive stimulation to manage symptoms, antipsychotic alcohol as needed, avoidant unnecessary restraints, and drug that may worsen delirium, anticholinergic, benzodiazepine, opioids. Psychosis distorted perception of reality, characterized by delusions, hallucinations, and or disorganized thoughts of speech. Can occur in patients with psychiatric illness or another medical condition or secondary substance medication use. So they will give you a case of a patient that presented to the emergency. He's hallucinating, and the symptoms started after he was up for the exam. He was in college, and he's common that he used substances, and he's having hypertension, which raises tachycardia, and he'll tell you what the reason of the psychosis was, what it is substance induced. Okay, delusions, false fixed idiosyncratic beliefs that persisted despite evidence to the contrary and are not typical of a patient cultural relation. A patient who believes that others are reading his thoughts. Types include erotomanic, grandiose, jealous, persecutory, somatic, mixed, and unspecified. Okay, disorganized thoughts, speech may be incoherent, word salad, tangential, or delayed, loose association. Okay, that is all hallucination, perceptions in the absence of external stimuli, seeing a light that is not actually present. Concept with misperception, which is illusion of real external stimuli. Types include hereditary hallucinations, more commonly due to psychiatric illness as schizophrenia than neurologic disease. Visual, more commonly due to neurologic disease, dementia, delirium, or drug intoxication than psychiatric illness. Tactile, common in alcohol, withdrawal, and stimulant use. Okay, cloniness, a type of delusion of parasitosis. Olfactory often occurs as an oral temporal epilepsy, burning rubber, and brain tumors. This is very characteristic. Gustatory, rare but seen in epilepsy. Hypnagogic occurs while going to sleep, sometimes in narcolepsy. Hypnopompic occurs while waking from sleep, get pumped up in the morning, sometimes in narcolepsy. Contrast with delusions, which are misperceptions of real external stimuli, mistaking a shadow for a black cat. Mood disorders, characterized by an abnormal range of moods or internal emotional states and loss of control over them. Abnormal range of moods or internal emotional states and loss of control over them. Severity of mood causes distress and impairment in social occupational function. Includes major depressive, bipolar, dysthymic, and cyclothymic disorders. Episodic superimposed psychotic features, delusions, hallucinations, disorganized speech, behavior may be present at anytime during mood episodes other than hypomania. We have MD, major depressive episode, with psychotic features, bipolar 1, bipolar 2, and schizoaffective disorder. Major depression, so to go down to depression. The blue is mania, hypomania, hypomania, dysthymia, depression. Major depression with psychotic features, we have major depression with the psychotic features. And the psychosis only occurs with mood episode. This is very important. Bipolar 1 requires one episode of mania, psychotic feature possible during manic or depressive episode. So the psychotic feature during depressive or during manic, this is like one episode of mania. The bipolar 2, one episode of hypomania and one major depressive episode. Okay. Psychotic features possible during major depressive episode but does not occur with hypomania. Okay, so the psychotic episodes with major depression but not with hypomania. Schizoaffective psychotic overlaps with mood episode but must occur by itself for more than 2 weeks. Must occur by itself. Here it is for more than 2 weeks. Okay. You're not supposed to know it from here. Yeah, this will give everything. Let's start. Okay, schizophrenia, spectrum disorders, schizophrenia, chronic illness causing profound functional impairment. Symptoms categories include positive associated with better prognosis, excessive or distorted functioning, example, hallucination, delusion, unusual thought processes, disorganized speech, bizarre behavior, negative symptoms, diminished functioning, flat or blunted affect, apathy, anhedonia, allergia, social withdrawal, cognitive reduced ability to understand or make plans, diminished working memory, inattention. Diagnosis requires more than 2 of the following active symptoms, including more than 1. Symptoms from 1 to 3. Illusions, hallucinations, often auditory, disorganized speech, disorganized or catatonic behavior, negative symptoms. So they will tell you delusions, hallucinations like she has been hearing voices telling her to take a lot away, or I've been hearing voices telling me whatever. This is hallucinations, auditory. Symptom onset more than 6 months prior to diagnosis. Requires more than 1 month of active symptoms over the past 6 months. Psychiatric disorder, let's see here, associated with anticholinergic activities. They ask you the pathway that is affected is increased dopamine from the mesolimbic system, increased cholinergic activity, and decreased dendritic branching. Ventriculomegaly on brain imaging, lifetime prevalence 1.5 males, more than females, present early in males, late teens to 20s, than in females, late 20s to early 30s. Increased risk of suicide, heavy cannabis use in adolescents is associated with increased incidence and worsening course of psychotic mood and anxiety disorder treatment. Antipsychotics, as risperidone, are first line. Negative symptoms often persist after treatment despite resolution symptoms or positive symptoms. These psychotic disorders, more than 1 symptom, lasting between one day and 1 month, usually stress related. So she will, like someone's going through a breakup and will have psychotic symptoms, more than 1 positive symptoms, which is the delusions, hallucinations, and that, but the duration is different. It will be from 1 day to 1 month. Schizophrenia 4, this will be more than 2 symptoms, lasting from 1 to 6 months. So this is 1 day to 1 month, 1 to 6 months, more than 6 months. Okay. More than 6 months prior to diagnosis requires more than 1 month of active symptoms over the past 6 months. Schizoaffective disorder, she has symptoms of both schizophrenia and mood disorders. Major depressive disorders or bipolar disorder differentiate from mood disorders. Psychotic features, patient must have more than 2 weeks of psychotic symptoms without a manic or depressive episode. Okay. Delusion disorders, more than 1 delusion, lasting for more than 1 month, but without a mood disorder or other psychotic symptoms. Delusion disorders, more than 1 delusions for more than 1 month without mood disorders or other psychotic features. Daily functioning, including socialization, may be impacted by pathological flexibility, but is otherwise unaffected, can be shared by individuals in close relationships. Okay, typical personality disorders, cluster A personality disorder that falls on the schizophrenia spectrum may include pre-psychotic episodes, delusions that are less frequent and severe than schizophrenia. So that just less frequent and severe. This is the cluster A personality. Typical eccentric appearance, beliefs and magical thinking. Yeah, this is very characteristic of beliefs and magical thinking. Interpersonal awkwardness included in the schizophrenia spectrum. Okay. Manic episodes, distinct period of abnormally and persistently elevated expansive or irritable mood and increased activity or energy. Diagnosis requires marked functional impairment with more than 3 of the following. Increase for more than 1 week of any duration if hospitalization is required. People with mania, fast, distractibility, impulsivity, indiscretion, seek pleasure without regard to consequences, hedonistic, grandiosity, inflated self-esteem. 5 years raising thoughts. A for activity, increased goal-directed activity. A for another, A for agitation, increased need for sleep, productiveness and pressure speech. So they tell you like the patient is having is very agitated and grandiose and all of that. Tell you like what else do you expect to have in this patient? Pressure speech. Okay, schizophrenia case will be very typical. They will ask about associated increased activity of the mesolimbic pathway. They will tell you that positive symptoms are associated with better prognosis. They will ask you what is the best treatment. It will be antipsychotics, so acting on T2 receptors, risperidone on the first line. Pre-psychotic disorders will be for more than 1 symptom for a month. The period is very important. Schizophrenia form will be the same thing for 1 to 6. Schizoaffective will be like a case of doing things that are inappropriate, hallucinating, and all of that. Most importantly, they'll tell you that the patient was hospitalized for psychotic symptoms, and between episodes there is no mood symptoms. So this is very important. More than 2 weeks of psychotic symptoms without a manic or this depressive episode, which is no mood symptoms. Delusion is very simple, just delusions. Patient thinks that the government is after him, and the patient thinks that the food is poison. Patient thinks that, but he has no any other symptoms. He has no evidence. So this is delusion. Manic episode is very easy. So hypomanic episode is similar to manic episode, except mood disturbance is not severe enough to cause marked impairment in social and or occupational function or in state hospitalization. Abnormal increased activity or energy usually present no psychotic features lasting for more than 4 consecutive days. Bipolar disorder, we have bipolar 1 and 2. Cyclothymic disorder. Bipolar 1 requires 1 type of episode. More than 1 manic episode. More than 1 manic episode plus or minus a hypomanic or this depressive episode may be separated by any length of time. Bipolar 2 requires 2 types of episode, hypomanic and depressive episode. No history of manic episode. Okay. Okay, bipolar disorder. Bipolar 1 requires 1 type of episode, more than 1 manic episode. A hypomanic or depressive episode may be separated by any length of time. Bipolar 2 requires 2 types of episodes, a hypomania and a depressive episode, no history of manic episode. So this is symptom mania. With a hypomania and depressive episode may be separated by any length of time. And bipolar 2 is a hypomania and a depressive episode together. Okay, no history of manic episode. Hypomania. Patient mood and functionally mood and functioning usually normalized between episodes. Easy depression can destabilize mood. High suicide risk. Treatment atypical antipsychotics, mood stabilizer, lamotrigine, atypical lamotrigine, lithium, valproate, carbamazepine. Atypical lithium, lamotrigine, valproate, carbamazepine. Cyclothymic disorder, a little less variable character. So yeah, a little less variable character. Atypical antipsychotics, as we said, risperidone. Okay, same as lithium for bipolar, lamotrigine, Steven Johnson, valproate, neurological defect, carbamazepine. 1 month. Psychothymic disorder, mild form of bipolar disorder, fluctuating between mild, depressive and hypomanic. Symptoms must last for more than 2 years, with symptoms present at least half of the time, with any remission lasting less than 2 months. Major depressive disorder, recurrent episodes lasting for more than 2 weeks, characterized by more than 5 of 9 diagnostic symptoms, including depressive mood or anhedonia, or irritability in children, sick, ECAPS. More than 2 weeks, characterized by more than 5 of 9. Symptoms include depressive mood and anhedonia. Okay, sleep disturbances. Interest, decreased interest in pleasurable activities, anedonia. Guilt or feeling of worthlessness, SIG, interest. S for sleep, I for interest, G for guilt, E for energy, C for concentration, A for appetite or changes, P for psychomotor rehabilitation, agitation, S for suicidal ideation seen. So you have to graph more than 5 of these for 2 weeks. Screen for previous manic or hypomanic episode or bipolar. Yeah, this is very important. You have a question on that. A patient with suicide. What is the first thing you should do? Is ask about any episode of mania. Treatment, CBT and SSRI are first line. Alternative include SNRI, metazapine, bupropion, ACT, and ketamine. Responses to significant loss, bereavement, natural disaster, disability, medicine, medical episode, diagnosis of MDD is made if criteria are met. MDD with psychotic features. MDD plus hallucinations or delusions. Yeah. So it's just major depression disorder, but with hallucinations and delusions. Psychotic features are typically more concurrent. Example, depressive themes of inadequacy, guilt, punishment, nihilism, disease, or death, and occurs only in the context of major depressive episodes versus affective disorder treatment, antidepressant with atypical antipsychotics, ECT. Okay. Persistent depressive disorders, also called dysthymia, often milder than MDD for more than 2 depressive symptoms, lasting for more than 2 years, increase for more than 1 year in children. Okay. With any remission, lasting less than 2 months. Less than 2 months. MDD with seasonal pattern, formerly called seasonal affective disorder. We didn't have any question on this. Major depressive episode occurring only during a particular season, usually winter, in more than 2 consecutive years, and in most years across a lifetime. Atypical symptoms, treatment, standard MDD therapies, but life plus life therapy. Depression with atypical features characterized by mood reactivity. Mood reactivity, transient improvement in response to a positive event, hypersomnia, hyperphagia. So mood activity, patient has depression but still is reactive to mood, and he has hypersomnia, he eats, hyperphagia and sleeps. So insomnia is sleeps, hyperphagia sleeps. Leading paralysis, heavy feeling of the oh, this is in a case, I got this in a case. Long-lasting interpersonal rejection sensitivity on this one too. Most common subtype of depression. Treatment, CBT and SSRI. MAO inhibitors are effective but on the first line because of their risk profile. Peripartum mood disturbances, onset during pregnancy or within 4 weeks of delivery, increased risk with history of mood disorders. Postpartum blues, 50%, 85% instance rate characterized by depressed affect, tearfulness, and fatigue starting 2-3 days after delivery, usually resolves within 2 weeks. Treatment supportive follow-up to assess for possible MDD with peripartum onset. MDD with peripartum onset, 15 to 10% incidence rate, formerly called postpartum depression. Meets MDD criteria with onset either during pregnancy or within 4 weeks after delivery. Treatment, CBT, SSRI, first line. Postpartum psychosis, 0.1 to 0.2 instance rate characterized by mood congruent delusions, hallucinations, and thoughts of harming the baby or self. Mood congruent delusions, hallucinations, and thoughts of harming the baby or self. Risk factors include first pregnancy, family history, bipolar disorder, psychotic disorder, recent medication change, treatment, hospitalization, and initiation of atypical antipsychotic. If insufficient, ECT may be used. Okay, treatment, hospitalization, and initiation of atypical antipsychotics. If insufficient, ECT may be used. Electroconvulsive therapy, rapid acting method to treat refractory depression. Depression with, yeah, he will ask a question like, what is the fastest? Patient is very came to the emergency and he wants to suicide and he wants to do it right now, and what is the fastest thing you should do? ECT. Rapid acting method to treat refractory depression. Depression with psychotic symptoms, catatonia, and acute suicidality, induces tonic seizures under general anesthesia. And neuromuscular blockage. So yeah, this is how you induce tonic seizure and anesthesia and neuromuscular blockage. Adverse effect include disorientation, headache, partial antiplator treated amnesia, usually results in 6 months. No absolute contraindications, safe in pregnant individuals and older are of this factor for suicidality. 6 sad version. This is the pneumonia. Sad versions are more likely to die from suicide. S for sex, male sex. A for age, young adults. D for depression. P for previous attempts. E for ethanol or drug use. R rational thinking plus. S for sickness, medical illness. O organized plan. N no spouse or other social support. Stats stated for future intent. Most common method in the US is firearm. Access to guns increases risk of suicide, death. Women try more often. Men die more often. Other risk factors include recent psychiatric hospitalization, family history, suicide, death. Protective factors include effective care for comorbidities, medical, familial or community connectedness, cultural, religious beliefs encouraging self-preservation and strong problem-solving skill. Anxiety disorders, inappropriate experiences of fear, worry, and their physical manifestations incongruent with the magnitude of the stressor. Symptoms are not attributable yet to another medical condition. Psychiatric disorders or hyperthyroidism or substance use includes panic disorders, phobia, generalized anxiety disorders, and selective mutism. Panic disorders, recurrent panic attacks. Let's just revise the questions here. So MDD with psychotic features, they will tell you like a patient having MDD, but he's hearing voices telling him that you don't deserve to live, all of that. So these are hallucinations with MDD. So this is MDD with psychotic features. Persistent depressive disorder that it's more than 2 years, as I said. So patients will be like, he's having MDD, while these symptoms started like 3 years ago. Postpartum psychosis, postpartum depression will have started just 2-3 days after delivery, and it's related to crying, tearfulness, and all of that. ACT is like patient having a plan to kill himself, and he has been depressed for a long time. And that was the fastest way. So risk factors for suicide, death. Protective factors, the most important risk factor is previous attempt. Anxiety disorder, panic disorders, recurrent panic attacks involving intense fear and discomfort, plus or minus unknown trigger. Attacks typically peaks in 10 minutes with more than 4 of the following. Okay, panic disorder, recurrent panic attacks involving intense fear and discomfort, plus or minus unknown trigger. Attacks typically peaks in 10 minutes and for more than 4 of the following palpitations, paresthesia, depersonalization, derealization, abdominal nausea, abdominal distress, nausea, intense fear of dying, intense fear of losing control, lightheadedness, chest pain, chills, jogging, sweating, shaking, shortness of breath, strong. So number 4 is very characteristic or very common in psychiatry, like number 4, more than 4 in panic. 4 weeks after delivery with postpartum depression. 4 weeks after delivery. Lasts for more than 4 consecutive days. Okay, let's go back to the panic. Strong genetic component increases risk of suicide. Diagnosis requires attack followed by more than 1 month of more than one of the following persistence, concern of additional attacks, worrying about consequences of attack, behavioral change related to the attack. Symptoms are systemic manifestations of fear. Treatment, CBT, SSRI, and vaccine are first line. Benzodiazepines are occasionally used in acute settings. Attack followed by more. Yeah, this is very characteristic. Persistent concern. Patient will be like, I don't know when is this going to happen again, and what I will do when that happened, so we'll have vaccine. Phobias, severe persistent more than 6 months fear of anxiety or anxiety due to presence or anticipation of specific object persecution. Person often recognized fears excessive. Treatment, CBT and exposure therapy. Social anxiety disorder, executive fear, embarrassment, civic fear of embarrassment in social situations in public. Speaking using public restrooms. Treatment, CBT, SSRI, SNRI. For performance type, example, anxiety restricted to public speaking. Use beta blockers or benzodiazepines are needed. Agoraphobia, intentional fear, anxiety, irrational fear, and anxiety, and or avoidance while facing or anticipating more than 2 specific situations. Public transportation, open closed spaces, lines, crowds, being outside of home. Symptoms stem from the concern that help or escape may be unavailable. Associated with panic disorders. Treatment, CBT, SSRI. Generalized anxiety disorders. Excessive anxiety and worry about different aspects of their life, work, school, whatever. Let's see the panic. So this is tax deadline. She says the worst part is that getting nervous of the day. I get really nervous. The most part I get nervous all the day. All of a sudden, and then feel shaky, dizziness. Yeah, it started. So it happened while I spoke to my book a few weeks ago, and I had to excuse myself. Worried about having this episode again in a meeting. This is another case. The patient has no history, has for alcohol. The patient describes episodes that come out of nowhere, shaky, sweaty, headache, nauseated. Okay. And the treatment is SSRI. This is another case of during some episode experienced dizziness, paralysis of the hands. The patient's husband explains that she had some symptoms before while getting blood drawing, and she's about this is phobia. Okay, wait. So this is related to blood drawing. This is phobia. 32 years old. His fear of elevators dates back childhood. Okay. 4 years old woman comes to the emergency department fearing she is having a heart attack while clutching her chest and breathing. I feel like I'm dying. This was the difference between empty. The pain resolves within 10 minutes without treatment, and I was taking the bus home from work when my chest started feeling very tight and lucky. My friends were there, but okay. So phobia is not an answer. It is a panic attack, also is not there. So agoraphobia. Okay, generalized anxiety, excessive anxiety and worry about different aspects of life for school children for most days of more than 6 months, treated with more than 3 of the following for adults. Well, more than 1 for kids, difficulty, concentrated crimes, we have difficulty crimes, concentrating, restlessness, irritability, muscle tensions, fatigue, low energy, sleep disturbance, anxiety, over crimes, treatment, CBT, SSRI, SNRI are first line. Yes, P1, TCAs, benzodiazepines are second line. Okay, obsessive compulsive disorders, crimes, generalized crimes, concentrating, restlessness, irritability, muscle tensions, fatigue, sleep disturbance. Yeah, you get it from the case, no need to remember this. Obsessive compulsive disorder. Most important thing it is as daily life, worrying about different aspects of daily life. Like she's worried about home, she's worried about work, she's worried about the children. That's it. Increase more than 3 of the following for others, more than 1 difficult. Okay. Muscle tension, yeah, muscle tension like neck pain or whatever. Irritable, restless, concentration, difficulty to sleep. Okay. Obsessive compulsive disorder, obsession. Recurring intrusive thoughts or sensations that can cause severe distress and or compulsions. Repetitive, often time-consuming actions that may relieve distress associated with the disorders. Okay. Poor insight into beliefs, action linked towards outcomes treatment, CBT and SSRI, clomipramine, venlafaxine. Our second line. Venlafaxine was also in the panic disorders and OCDs. What is most obsessions? Recurring intrusive thoughts. So the obsessions causes severe distress. Compulsions is the time-consuming action that causes relief, the distress. Okay. And this is the thoughts. Obsessions are the thoughts. Compulsions are the actions. Body dysmorphic disorders, preoccupation with minor or imagined defects in appearance causes significant emotional distress, repetitive appearance-related behaviors, nerve checking, excessive grooming, common in eating disorders, treating CBT. Trichotillomania. Trichotillomania is compulsivity point out one's hair, causing significant distress and resistance despite attempt to stop. Presents with areas of thinking, hair or baldness on any area of the body. Most commonly, the scalp remaining hair shafts are of different length versus alopecia. Incidence highest in childhood, but spans all ages. Treatment, CBT, SRI. Trauma and stress-related disorders, adjustment disorders, emotional or behavioral symptoms, anxiety outbursts that occurs within 3 months of an identifiable psychosocial situation, stressors, divorce, illness. Okay, emotional behavior symptoms, anxiety outbursts that occurs within 3 months of an identified psychosocial stress, divorce, illness. That is less than 6 months. Okay, so this occurs within 3 months of the stress and lasting for less than 6 months. When the stress has any symptoms do not meet criteria of another psychiatric illness. If symptoms persist more than 6 months after stress and evaluate for other explanation. MDD, major depressive disorders, or generalized anxiety disorder treatment is CBD, social antidepressants, and anxiolytics, medical research. PTSD, experiencing, witnessing, or discovering that a loved one has experienced a life-threatening situation, injury, sexual assault, persistent hyperarousal, avoidance, hard. Okay, PTSD, experiencing, witnessing, or discovering that a loved one has experienced a life-threatening situation, as essentially sexual assault, will lead to persistent hard hyperarousal, avoidance, associated to lie, intrusively experiencing the event, nightmares, flashbacks, changes in cognition or mood, fear, horror, distress. Okay, having PTSD is hard. Disturbance lasts for more than 1 month with significant distress or impaired function. Treatment, CBT, SSRI, and venlafaxine. So venlafaxine is used again here. PTSD, OCD, panic disorders, and it is the first line. Prazosin can reduce nightmares. Prazosin, what is prazosin? Prazosin can reduce nightmares. Okay, then we have acute stress disorders. Alpha 1 blocker, exact. That's tamsulosin. It's used for the non-specific hyperplasia. PTSD also prazosin and PTSD can reduce nightmares. Acute, then we have acute stress disorder lasts between 3 days and 1 month. Treatment, CBT, pharmacotherapy is usually not indicated. Okay, let's see these questions. 28 years old comes to the 29 years old comes to the office. A volunteer, struggling to concentrate ever since missing a child who had been badly burned. So they get flashbacks. Another question. She was sexually assaulted in the parking lot. She will space out, she will feel like she's going crazy, and she will hear voices, hallucination. That's PTSD. Diagnostic criteria by symptom duration. Narcolepsy, 3 months. Childhood disorders, tics, 1 year. Disruptive mood dysregulation, 1 year. ADHD, specific learning, oppositional, defiant. Phobias, adjustment, generalized anxiety, schizophrenia, all of these 6 months. 3 months, we only have PTSD. Selective meters is 1 month. Separation anxiety, panic, acute stress less than 1 month. PTSD from 1 month to 3 months. Okay. Okay, personality disorders, inflexible, maladaptive, pervasive pattern of behavior causing subjective distress, and impaired functioning. Persons usually not aware of the problem, egocentric, usually present by early adulthood, contrast with personality trait, non-pathologic enduring pattern of perceptive and behavior. Personality trait, non-pathologic enduring pattern of perception and behavior. So the trait is non-pathologic. Treat three clusters. Cluster A, remember, as weird. So we have weird, wild, worried. Weird, wild, worried. Cluster A, odd or eccentric, inability to develop meaningful social relationships, no psychosis, genetic association with schizophrenia. Okay, cluster B, remember, wild, dramatic, emotional, or erratic genetic association with mood disorders and substance use. Cluster C is worried, anxious, fearful, genetic association with anxiety disorders. Okay. Let's go for cluster A. Is paranoid. She's deeply paranoid, pervasive distress, accusatory, suspiciousness, hyper-vigilance, and a profound cynical view of the world. So, accusatory. Cluster A, accusatory. Let's see this case. 8 is emergency department, by to the brain and the course, and emergency appendectomy following a successful therapy. I have earned everything I have on my own, and this hospital isn't going to get any of it. Which of the following? Okay, I haven't talked to my family in 20 years, and I wouldn't call anyone my friend. So, just paranoid. His family, he doesn't trust his family, he doesn't trust the hospital after they did life-saving surgery. So, this is paranoid, accusatory. Schizoid Schizoid prefers socially true and solitary activity versus avoidant. Limited emotional expression, indifferent to others' opinions, aloof. Eccentric, okay, schizoid prefers loneliness. Social withdrawals, solitary activity, aloof. So let's see. 40-year-old man comes to the office for evaluation of discomfort in his rest. He thinks his symptoms may be related to typing all day. The patient is a social entry, avoiding washing his okay. And prefers to work remotely from home to avoid wasting time talking and interacting with co-workers. He spends a large portion of his childhood distant, simply building electronic devices and had few friends. His affect appears constricted. His response to questions are limited. So this is schizoid. Why it's not schizotypial? Because schizotypial, as we said, he has to have like something like magical thinking, eccentric behavior, and like telepathy and all of that. Okay, schizotypial, eccentric opinions, believes magical thinking, interpersonal awkwardness, including on the schizophrenia spectrum. For now, schizotypial. 4 odd type thoughts. Okay. I always listen to my bodily rhythms when deciding whether to take medications on a particular day. Okay, the patient believes that crystal usually has healing powers. So this is magical. So this is schizotypial. Eccentric appearance or beliefs are magical thinking. Okay. Typical odd type. Cluster B, we said wild. So this is antisocial, borderline, histrionic, narcissistic. So antisocial, disregard for the rights of others with lack of remorse, bad. Involves criminality, impulsivity, hostility, and manipulation. Sociopath. Males more than females must be more than 80 years old with evidence of conduct disorders. Answer before age 15. If patient is less than 18, diagnosis conduct disorder. Okay, so we have two disorders: conduct and antisocial personality disorder. Antisocial is disregard for the rights of others with lack of remorse, bad. Involves criminality, impulsivity, hostility, manipulation. Sociopath. Males more than females be more than 18 years old with evidence of conduct disorders. Okay, let's see. So he's 19. Okay, he said that the patient is start operating a fight club. Okay, and he says that he has entrepreneurial skills that have made him a doctor. He has been fired from multiple jobs recently while working in the car system due to getting into arguments with co-workers. I was only late a few times. Okay, haven't ever been late before, doc. Okay, he was currently thrown transferred down the detention center for tampering with his teacher's car brakes after failing a class. So he's antisocial. Borderline, unstable mood and interpersonal relationship, fear of abandonment, impulsivity, self-mutilation, suicidality, sense of emotional emptiness, borderline females, more than males. Splitting is a major defense against treatment, dialectical behavior therapy. Okay. So this is going to use all the with life to socialization. The patient's grasping of intense sadness, emptiness, and emptiness, sadness, despair for the past week following the breakup of her month-long relationship. So it's only 1 month long romantic relationship. For the past week, she has had difficulty falling and staying asleep, but has had no change in appetite, energy level, or concentration. She feels betrayed by her boyfriend and is furious at her parents for turning against her since the last week. The patient has been going to bars. This is the thing that gives away. Going to bars, unsafe sex, drinking excessively, mood swings. She has a history of suicide attempts. Okay. Histrionic, attention-seeking, dramatic speech, and emotional expression. Attention-seeking, dramatic speech, emotional expression, shallow, libel emotion, sexually provocative. May use physical appearance to draw attention, flamboyant. Histrionic, oh god. Attention-seeking, dramatic speech, and emotional expression, shallow, libel emotion, sexually provocative. May use physical appearance to draw attention. Okay, personality disorders: inflexible, maladaptive, rigidity, pervasive, patterns of behavior causing subjective distress and or impaired functioning. Person is usually not aware of problem, ego, tonic. Usually possessed by early adult contrast with personality traits, which is non-pathologic, including pattern of pervasive or perception and behavior. 3 clusters we have: A, B, and C. Weird, wild, void. E-I-O. So weird, wild, void. So the cluster A, odd or eccentric, inability to develop meaningful social relationship, no psychotic, no psychos, genetic association with schizophrenia. So the odd with the weird one is schizophrenic. B, wild, that's dramatic, emotional, adaptive, genetic association with mood disorders, substance use. That's wild, substance and mood disorders. Okay. Cluster C, worried, anxious, fearful, genetic association with anxiety disorders. Oh, that's problem. That's the worries. And cluster C, anxiety. Okay, cluster A, that's the weird one. Paranoid, so pervasive, distress, accusatory, suspicious, hypervigilance, whatever. And a profoundly cynical view of the world. Schizoid prefers social. Okay, let's say the paranoid person would be like a person that came to the hospital due to an appendicitis emergency, and the doctors made an operation and they saved his life, and then he was like, oh, you just want my money, you didn't want to say the surgery wasn't necessary, and then we asked about family members, he'd be like, I don't talk to my family for like 10 years or something, do you think I trust everyone? That's a paranoid person. Schizoid prefers social withdrawal and solitary activities versus avoidant. Limited emotional expression individuals and indifferent to others' opinions, aloof. So that's the person would be like, he works on his own, and that's since childhood he didn't have any other friends in his childhood. He used to play solitary games and disassemble things and that while working, avoid talking to others so that the co-workers avoid talking to co-workers so that he doesn't waste time. Schizotypial, that's the crazy one, the magical one, typical. So eccentric appearance, odd beliefs and magical thinking, interpersonal awkwardness, including on the schizophrenia spectrum. For now, schizotypial for odd type thoughts. So this is like a patient would be like, I have magical crystals that heals everyone. I can predict the weather by counting my garden flowers. I can things like that. Antisocial disregard for the rights of others with lack of remorse, bad. Involves criminality, impulsivity, hostility, manipulation, sociopath. Males more than females must be more than 18 years old with evidence of conduct disorder. So he has to have evidence of conduct disorder onset before the age of 15. If patient is less than 18, diagnosed as conduct disorder. So this is the patient would be like, he'll do criminal things, he steals, he do bad things, and a childhood he would be like what is in juvenile center, whatever. So yeah, this is antisocial. Borderline, unstable mood, interpersonal relationship, fear of abandonment, impulsivity, self-mutilation, suicidality, sense of emotional emptiness, borderline, female, more than male. Splitting is a major defense mechanism. Treatment, dialectical behavior therapy. Okay, this is a patient that doesn't have stable relationships. It's like a female patient that came to the emergency. She was depressed because she broke up with 1 month long relationship, and then she started going to bars, drinking, doing crazy things. So that's borderline. Histrionic, attention-seeking, dramatic speech and emotional expression, shallow, libel emotion, sexually provocative. May use physical appearance to draw attention, flamboyant. That's the weird one. Okay, is it the weird? No, that's not wild. Borderline, that's wild. Antisocial, that's wild. Histrionic, okay, wild. Attention-seeking, sexually provocative, libel emotions, that's wild. Okay, narcissistic, okay, that's wild. Grandiosity, sense of entitlement, lacks empathy. Oh, lacks empathy. Oh god. And requires excessive admiration, often demands the best and reacts to criticism with rage and defensiveness. Must be the best, fragile self-esteem, often envious of others. Okay. Cluster C, avoidant, hypersensitive to rejection and criticism, socially inhibited, timid, cowardly, feeling of inadequacy, desires relationships with others, schizoid. Okay, so this is the keyword, hypersensitive to rejection. Okay, she would be like, I don't want to take, someone was offered a title in his job, like a supervisor title, something like that, but she was like, oh, I don't want to accept, I don't want people to if something happened, they would blame me and all that, feeling of inadequacy, exactly, feeling of inadequacy, desires relationships with others, versus schizoid. Okay, so schizoid doesn't, is alone, but avoidant is like, okay, desires, yeah, she's alone, but she would like to have a relationship one day, she wishes to get married and all that. Socially inhibited, timid, cowardly, obsessive compulsive, preoccupation with order, perfectionism, and control, obsessive compulsive, eccentric behavior, consistent with one's own life, believing that attitudes versus OCD. Okay, so this is not OCD, this is a personality disorder, preoccupation with order, perfectionism, and control, egocentric behavior, consistent with one's own belief and attitudes. Okay, dependent. Okay, dependent, excessive need for support, clingy, oh god, clingy, submissive, low self-esteem, patience gets often stuck in an abusive relationship. Okay, wow, reading all these things reminds you of yourself at sometimes or some people. Okay, let's continue. Okay, malingering. These symptoms are intentional, motivation is intentional, patients consciously fakes, profound, exaggerates, or claims to have a disorder in order to attain specific secondary external gain. Example, avoiding work, obtaining compensation, poor compliance with treatment or follow-up of diagnostic tests. Okay, complaint exceeds after gain, versus a fictitious disorder. So this is simply they'll present you with a patient that is complaining of abdominal pain and all of that, or something, but he would refuse to do any invasive procedures, even though the even though everything is normal. So, and he would usually ask, like, can I get a paper so that I give it to work to get a day off or something. Factitious disorder symptoms are intentional, motivation is unconscious. Okay, so this is the motivation is unconscious. Consciously creates physical or psychological symptoms in order to assume sick rule and to get medical attention and sympathy. Primary intention. Okay, so they only need sympathy, and it's common in health workers like nurses and all that. And sometimes it'd be like patient they admitted with like ulcers on the hand, the redness and hypersensitivity, and it happened in the past, and the culture shows E. coli. And that's what factitious disorder imposed on self, factitious disorder imposed on another, formally called whatever. Chronic factitious disorder with predominantly physical signs and symptoms characterized by a history of multiple hospital admissions and willingness to undergo invasive procedure. This one he's willing to undergo invasive surgical procedures, more common in females and healthcare workers, exactly. This one, the other one, opposed to others, Munchausen syndrome by proxy. Munchausen syndrome by proxy illness in an individual being cared for, most often a child, also seen in disabled or older adults, is directly caused physically harming a child or fabricated lying about a child's symptoms put by the caregiver for a form of child and elder abuse. Okay. Somatic symptom identity disorder. Symptoms are unconscious. Motivation is unconscious. So there's symptoms unconscious, motivation unconscious. Here, the motivation is unconscious, but symptom is the symptom. Here, there's intentional motivation and symptoms is intentional. Okay. Somatic symptoms, both are unconscious. Category of disorder characterized by physical symptoms causing significant distress or impairment. Symptoms not intentionally produced or feigned. So somatic symptom syndrome. More than one body complaints, abdominal pain, fatigue, lasting months, associated with excessive persistent thoughts and anxiety about symptoms. So the patient will come to the hospital being like, I have nausea and vomit, nausea and headache and abdominal pain and all of that. May co-occur with medical and treatment with the office visit. Okay, this is the office visit with the same physician with the goals of addressing active symptoms, reassuring the patient. So this is the I got a question about this one. So yeah, they'll tell you what is the, even though it is a psychiatric illness, you won't refer to the psychiatrist, you will do regular office visits. B, showing the patient avoiding unnecessary medications. Conversion disorder, also called functional neurologic symptom disorder, unexplained loss of sensory or motor function, paralysis, blindness, mutism, often following an acute specification, may be unaware but indifferent towards symptoms. More common in females, adolescents, and young adults. Conversion disorders, also called functional neurologic symptom disorder. So this is the patient will be like, yeah, unexplained loss of often following acute stress. This is important. So a patient would present after the loss of a loved one by loss of sensation in her left leg or right leg or right arm and all of that. And yeah, this is conversion illness and anxiety. So the patient with acquiring or having disease, often despite medical evaluation and assurance, minimal to no somatic symptoms. So yeah, patient would be like, would come to the emergency about the fear, patient with fear of having like colon cancer. The patient would be like, I'm afraid I might have colon cancer, and my friend at work had it, and the last period I've been having feeling like having gases or whatever. So illness and anxiety. So malingering is factitious. We said that malingering what are intentions is motivation. Factitious, there's no motivation. Malingering motivation is like I want to take a day off work or something. Factitious, there's no motivation. They just want to feel the get empathy, whatever. Somatic, there's nothing, no symptoms, no motivation. Okay. Eating disorders most common in young women. And also intense fear of weight gain, overvaluation of thinness, and body image distortion leading to caloric restriction, severe weight loss, resulting in inappropriately low BMI. This is the very most important thing. The BMI low in anorexia nervosa. Physiological disturbances may present as bradycardia, hypertension, hypothermia, hypothyroidism, osteoporosis, lanugo, amenorrhea, local intake, decreased leptin, or decreased GnRH, decreasing LH. If it's H, decreasing estrogen leading to amenorrhea. Binge eating, version type, recurrent version behavior, laxative or diuretic use, self-inducing vomiting or binge eating over the last 3 months associated with hypokalemia. Okay. Restricting type, these are types of anorexia nervosa. Restricting type, primary disordered behavior, including dieting, fasting and or over-exercising, recurrent recurring version behavior or binge eating over the last 3 months. The feeding syndrome often occurs in significantly malnourished patients with sudden increased caloric intake, increasing insulin decrease, phosphate, potassium, magnesium, glucose complication, abnormal diseases. Treatment, nutrition, rehabilitation, psychotherapy, olanzapine. Okay. So the feeding syndrome is sudden increase in caloric intake or lead to cardiac complications, diseases, randomized. Anorexia nervosa would be like a patient that is an adult. And she used to, she'd be like feeling fatigue, decreased exercise. She'd be like, I used to run 5 miles every day. I need to keep running so I don't get fat. She for instance, she'll have significantly dry skin, pain, bilateral gland swelling, pharyngeal edema, hyperactive bowel sounds, and they might be very low. These are all signs of induced vomiting. So yeah, bulimia nervosa. And they'll ask you like, the patient is, wants to start a vegetarian diet, or you'll ask her about the goals. Predominantly positive psychotic symptoms. Okay. Then we move to bulimia nervosa. Recurrent episodes of binge eating with compensatory purging behavior at least weekly over the last 3 months. BMI of normal or slightly overweight, which is that's the difference between them. Associated with vertical gland hypertrophy, may see increased serum amylase in amylase erosion. So yeah, bulimia is associated with vertical gland hypertrophy. May see increased serum amylase in amylase erosion, otherwise syndrome, electrolyte disturbance. That's all from vomiting, metabolic acidosis, nodal hand calluses from induced vomiting, suicide. Treatment, psychotherapy, nutrition, rehabilitation, antidepressant, SSRI, propaganda is contraindicated due to seizure risk. Propaganda is contraindicated due to seizure risk. Okay. Binge eating disorder, recurring episodes of binge eating without purging behaviors at least weekly over the last 3 months. Increased diabetes risk, most common eating disorders in adults. Psychotherapy, first line, SSRI, less whatever. Let's take some vitamin. Bicarb recurrent episodes of eating unfood substance, ice, dirt, hair, pin chips, over a period of more than 1 month. That unculturally or developmentally recognized as normal may produce temporary emotional relief common in children and during pregnancy. Symptoms associated with malnutrition, iron deficiency, anemia, developmental disabilities, emotional trauma, psychotherapy, and nutritional rehabilitation. First line, SSRI. Second line, gender dysphoria. Okay, this is the patient's significant incongruence between one's gender identity and one's gender assigned at birth, lasting for more than 6 months and leading to persistent distance. This is the most important thing. Individuals experience marked discomfort with their assigned gender, which interferes with social, academic, and other areas of function. Individuals may pursue multiple domains of gender affirmation, including social, legal, and medical transgender. Any individual who transiently or persistently experiences incongruence between their gender identity and the gender assigned at birth. Some individuals who are transgender experience gender dysphoria. Non-conformity to one's assigned gender itself is not a mental disorder. Non-conformity to one's assigned gender itself is not a mental disorder. Okay. Sexual dysfunction includes sexual desire disorders, hyperactive sexual desire, sexual aversion, sexual arousal disorders, erectile dysfunction, orgasmic disorders, and orgasmic penetration. Sexual pain disorders, genital pain, penetration disorders. Okay, differential diagnosis includes which is psychological, if not time, erection syndrome, exactly. So this is easy. Endocrine, diabetes, leucistin, neurogenic, postoperative spinal cord injury, insufficient blood flow, atherosclerosis, substance, antihypertensive, antidepressant, ethanol. So antihypertensive, antidepressants, SSRI, ethanol, of course, atherosclerosis, neurogenic, postoperative spinal cord, diabetes, and leucistin. Here they tell you like a patient that is likes wearing male patient likes wearing female clothes or something, and he's feeling distressed about his gender, so that's gender dysphoria. Like patients that after pregnancy she's consuming ice, eating blood flies and all that. Binge eating, the patient like eats whole pizza by herself and lots of other. Okay, and her BMI is not changed or maybe increased. Same as bulimia nervosa, but bulimia nervosa will have signs of induced vomiting. Okay, first one thing about the difference between bulimia nervosa and binge eating and anorexia nervosa is that anorexia nervosa, the BMI is low. Bulimia nervosa, they do compensatory action to compensate for the binge eating. Okay, but binge eating, there's no compensatory action. Here, they would like exercise excessively after they eat. They would just vomit. They would induce vomiting. They would fast. They would do something to compensate. Binge eating, they won't do anything. You just feel bad. Sleep terror disorder, periods of inconsolable terror with screaming in the middle of the night. Most common children often occurs during sleep or slow wave deep stage. And 3, non-REM sleep with no memory of the arousal episode. This is a typical case, as opposed to nightmares that occurs during REM sleep, remembering and scheduling triggers, including emotion, stress, fever, lack of sleep, usually self-limited. So this is a patient, like a young patient, that would every after 2 hours of sleeping, they would wake up and scream and cry, and the mother would hug him, and he would go back to sleep, and the next morning he won't remember anything. So that's a sleep terror. Any basis, nighttime urinary incontinence more than 2 times per week for more than 3 months. In person, more than 5 years. Okay, so it's nighttime urinary incontinence for more than 2 times. Nighttime urinary incontinence more than 2 times a week for more than 3 months. In person, more than 5 years old. First line treatment is behavior modifications scheduled. Avoids nighttime fluid restriction and positive reinforcement. For classic cases, bedwetting, alarm, oral, is ADH analog preferred over imipramine due to fewer adverse effects. Okay. Narcolepsy, excessive daytime sleepiness despite awakening when rested. With regard to episodes of rapid onset of sleepiness more than 3 times per week for the last 3 months. Due to decreased orexin hypotension, this is a question they ask about this. Reduction in the lateral hypothalamus and dysregulated sleep cycle associated with hypnopompic just before going to bed or hypnopompic just after waking up in the morning. Hallucinations. Okay, there are hallucinations. Nocturnal and narcoleptic sleep episodes that start with REM sleep paralysis. Cataplexy, loss of all muscle tone following strong emotional stimulus such as laughter. Treatment, good sleep hygiene, scheduled naps, regular sleep schedule, daytime stimulants, excessive amphetamine, more than and all nighttime. Sodium oxybate, GHB. Okay. Substance use disorder, maladaptive pattern of substance use involving more than 2 of the following in the past year. Tolerance, withdrawal, intense, distracting cravings, using more or longer than intended, persistent desire but inability to cut down. Time-consuming substance acquisition, use or recovery, impaired function at work, school, or home, social or interpersonal conflicts, reduced recreation activities, more than one episode of use involving danger, unsafe sex, driving while impaired, continued use despite awareness of harm. Okay, wow. So in case of appropriate medical treatment with prescribed medications, opioid analgesics, for example, sedatives, stimulants, symptoms of tolerance and withdrawal do not indicate a substance use disorder. Gambling disorder is persistent, recurrent, problematic gambling that occurs, that cannot be better explained as a manic episode. Diagnosed, in manic episode, they usually start gambling and spending money responsibly on that. Okay, diagnosed made if patient meets more than 4 different criteria. We said that 4 is the lucky number in psychiatry, so yeah. Is preoccupied with gambling. Is preoccupied with gambling. Requires more gambling to reach desired level of excitement. So yeah, preoccupied with more gambling to reach desired level of excitement. Had failed efforts to limit cutbacks. Stop gambling. Becomes restless, negative, limiting or attempting to stop gambling. Gambles to escape or relieve feelings of helplessness, guilt, anxiety, depression. After losing money, gambling continues gambling, attempt to recover losses. Lies to conceal the extent of gambling, puts at risk or has no significant relationships, careers or academic pursuits because of gambling. Relies on money from others to fix financial collapses due to gambling. Treatment is psychotherapy. Okay, so trans theoretical model of change, pre-contemplation, denies problem and its consequences. Encourage the motivation strategies that you'll do is encourage introspection, which is use patient's personal priorities and explain risks, affirm your availability to the patient. Contemplation acknowledges problem but is ambivalent or unwilling to change. He knows that there is a problem but he doesn't want to change. Discuss pros and cons of maintaining pros of changing and cons of maintaining current behavior, such as means to support behavior change, preparation or determination. Committed to and planning for behavior change. Employ motivation interview reviewing. Encourage initial changes, promote expectations for positive. I can't read. Employ. Okay, so preparation, employ motivation interviewing. Okay, good. Encourage initial change and promote expectations for positive results. Provide resources to assess for in planning. So this is the plan. You can help it unmotivated. Action willpower executes a plan and demonstrates a change in behavior. Assist with strategy for self-efficacy, contingency, management, and coping with situations that triggers behavior. Maintenance. New behaviors become sustained. Integrate into personal identity and lifestyle. Reinforce developing habits. Evaluate and mitigate relapse. Risk. Praise. Purpose. Relapse. Regression to prior behavior does not always occur. Varies based on degree of regression. Economy. Return to change. Encourage return to change. This is easy. That's all. Just provide reassurance that change remains possible. Okay. Let's start disease stuff. Okay, starting with serotonin syndrome, psychiatric emergency, serotonin syndrome, any drug that increases 5-HT, psychiatric drugs, inhibitors, SSRI, SNRI, TCAs, vilazodone, vortioxetine, buspirone, non-psychiatric drugs, tramadol, lacetrone, triptazine, zolid, MDMA, methyltrophan, mipridine, ST Jones ward, 3-active manifestation, increased AAs, activity in neuromuscular, clonic, hyperplexia, hyperthermia, tremors, seizures, autonomic instability, hyperthermia, diaphoresis, diarrhea, altered mental status. Treatment is benzodiazepine, so neuroleptic syndrome started with benzodiazepine supported, then cyproheptadine, 5-HT2, receptor antagonist, if no improvement, prevention, avoid stimulants, simultaneous synergistic drugs allow wash out period between them. So they ask like a patient was asked to stop the drug 2 weeks before starting another, why to allow the wash out of the drug and avoid serotonin syndrome. Another question here is the patient was taking a drug, which one was it that led to serotonin syndrome? Well, tramadol, and that's tramadol, triptazine, zolid, any of these drugs. Okay, hypertensive crisis, eating time foods, HG, skewed meats, wine, chocolate, while taking inhibitors, insufficient push-up period when switching to antidepressant. Switching antidepressant to or from inhibitors. Hypertensive crisis, diabetes, species, other neurotransmitters, norepinephrine, and synaptic increase in estimations, and the treatment will be phenethylamine. So this is alpha-1 blocker, and hypertensive crisis will be the patient was treated for treatment-resistant depression with inhibitors because it is for treatment-resistant depression, and he went to a restaurant, ate meat and cheese, and then developed hypertension, tachycardia, and blurred vision, headache, severe headache, and all that. This is hypertensive crisis, and the treatment is phenethylamine. Neuroleptic malignant syndrome, antipsychotic, typical, more than typical, plus genetic disposition will lead to malignant fever, which is M for microglinuria, F for fever, encephalopathy, vitals are unstable, enzymes are increased, CK, muscle rigidity, led which, and the treatment is naturally dopaminergics, example, promptine, amantadine, benzodiazepines, discontinued positive agents. So benzodiazepines used for neuroleptic malignant syndrome and serotonin syndrome. Here it is naturally promptine, amantadine, and here is benzodiazepine, cyproheptadine. Okay. Neuroleptic malignant syndrome, the classical like a patient was treated with a drug and led to muscle rigidity, was unable to move after being treated, and all of that. So it's neuroleptic malignant syndrome. It is related to dopamine. Okay, then delirium tremens. Alcohol withdrawal occurs 2 to 4 days after last drink, as seen in hospital settings when inpatient cannot drink, altered mental status, hallucination, autonomic hyperactivity, anxiety, seizures, tremors, psychomotor agitation, insomnia, nausea. Long-acting benzodiazepines is the treatment. Okay, longer-acting benzodiazepines. So they ask you like a patient that came, and it is neuroleptic malignant syndrome, came to the hospital, increased activity for the following. It is NMDA because chronic use of alcohol will lead to GABA receptors downregulation and MDA receptor upregulation. So when you stop it, the upregulated NMDA receptor will lead to that withdrawal effect of alcohol. Here is another case where the patient is a regular drinker. Which of the following signs most likely to appear earliest is tremors. Here is neuroleptic malignant syndrome, asking about which of the following is the explanation. Neuroleptic. Another case here asking about flufenazine is most likely to cause muscle rigidity, which is neuroleptic, and which of the following neurotransmitter is dysregulated dopamine. Acute dystonia, typical antipsychotic, anticonvulsants, carbamazepine, metoclopramide, sudden onset of muscle spasm, stiffness, and or okay, sudden onset acute dystonia, typical antipsychotics, anticonvulsants, anticonvulsant, example carbamazepine, and metoclopramide will cause acute dystonia. Sudden onset of muscle spasm, stiffness, and or oculogyric crisis occurring hours 2 days after medication use can lead to laryngospasm requiring intubation. Treatment for acute dystonia is benztropine and diphenhydramine, so easy. Okay, lithium toxicity increase, lithium dosage will decrease or decrease renal elimination due to acute kidney injury. Medication affecting clearance as ACE inhibitors. Thiazide. and non-steroidals TAN, TAN, T4-thiazide, A4-ACE, and for non-steroidals naltrexone, window, nausea, vomiting, slurred speech, hyperreflexia, seizures, and ataxia, nephrogenic diabetes insipidus. Discontinue the treatment is discontinue lithium hydrate aggressively with isotonic sodium chloride and consider hemodialysis. Isotonic sodium chloride and consider hemodialysis. Tricyclic antidepressant toxicity, tricyclic antidepressant overdose, sedation, anticholinergic effects, prolonged QT, and QRS, tricyclic convulsions, coma, cardiac toxicity, arrhythmia due to sodium channel inhibition. Yeah. Supportive treatment, monitor ECG and sodium bicarb, prevent arrhythmia, activated charcoal. Next, we go to the psychoactive drug intoxication and withdrawal. This is a patient with symptoms likely to potentiate tetanus. Okay, starting with psychoactive drug intoxication and withdrawal. So these are drugs, depressants and stimulants. Okay, starting with depressants, first one is alcohol. We have the mechanism, intoxication, withdrawal. The intoxication, we have non-specific mood elevation. Okay, these are non-specific symptoms of mood elevation, decreasing anxiety, sedation, behavior disinhibition, respiratory depression. Withdrawal non-specific will be anxiety, or the depressants, withdrawal from depressants will cause anxiety, tremors, seizures, and insomnia. Seizures and insomnia. Okay, alcohol, first one, GABA A receptor positive allosteric modulator. Positive allosteric modulator inhibits glutamate, induced excitation of an MDA. Okay, emotional lability. Emotional lability, slurred speech, ataxia, coma, blackouts. AST value is 2 multiplied by ALT value. Dose to alcohol. Okay. Treatment, supportive fluid, antiemetics. Withdrawal will be adaptation, causes increased glutamate receptors. Adaptation increases glutamate receptors. Symptoms result from unregulated excess excitation. Treatment, long-acting benzodiazepine. Long-acting benzodiazepine, as in this question here. Chlordiazepoxide. Chlordiazepoxide is a long-acting benzodiazepine. Treatment of alcohol withdrawal. And diazepam, long-acting. Okay. We have here alcohol hallucination starting from the 0 to 6 hours. Will be tremors is the first thing, then insomnia, diaphoresis, agitation, anxiety, upset, withdrawal, seizures, alcohol hallucination, then delirium tremors after 2 days. Okay, barbiturates, GABA A receptor positive allosteric modulator, same as alcohol. And low safety margin, multiple respiratory depression. These are the intoxications will cause multiple respiratory depression. Treatment symptom management, example, assist respiration and increased blood pressure. Assist respiration and increased blood pressure. Then we have the intoxication withdrawal, delirium, life-threatening cardiovascular collapse, delirium, life-threatening cardiovascular collapse. Benzodiazepine, GABA A receptor positive allosteric modulator, same as barbiturates and alcohol. Greater safety margin. Intoxication will cause ataxia, minor respiratory depression. Treatment is flumazenil. This is a very important question. Benzodiazepine receptor antagonists, the withdrawal will cause seizures. Okay, this is important. Sleep disturbance and depression. Opioids. Here's a question. Let's see the questions on benzodiazepines. This is a case of acute patient is hospitalized and started to have anxiety and tremulous. This is alcohol withdrawal treated with chlordiazepine, long-acting diazepam. Okay. Chlordiazepam, are the first line therapy for psychomotor agitation associated with alcohol withdrawal and to prevent progression to seizures and delirium. Diazepam, and chlordiazepam. This question is a patient. Which of the following mechanism of action of the drug? And anxiety, she's having panic attacks. The patient diagnosed with panic disorder. After discussion, she decided to pursue cognitive behavior short-term anxiolytic medication. So this is the benzodiazepine, and the benzodiazepine increases the frequency, benzo-frequency of chloride channel coupling, not the duration, the frequency. Chlordiazepam and chlordiazepam. This is another question. Mechanism of action of the medications she received. Diagnosed with panic disorder. Mechanism of action of benzodiazepine bind allosteric to GABA receptors. Opioid receptor modulator. Opioid receptor modulator. Intoxication will be activation of MU receptor. MU receptor causes protypic effect of meiosis, pinpoint pupil. This is very characteristic and important. Opioid is pinpoint pupil. Meiosis, pinpoint pupil. Decrease GI. Decrease GI motility, respiration, CNS depression, euphoria, decreased gag reflex, seizures. Most common cause of drug overdose, death. Overdose treatment is naloxone. Overdose treatment is naloxone. Then we have mydriasis, diarrhea, flu-like symptoms, rhinorrhea, yawning, nausea. These are the withdrawal. Of opioid will be the opposite of meiosis, mydriasis. And diarrhea. Okay, because MU receptors, respiratory, CNS depression, euphoria. Diarrhea, flu-like symptoms, rhinorrhea, yawning, nausea, sweating, bowel erection, cold turkey, lacrimation. Treatment, symptom management, methadone and buprenorphine. Inhalants enhance GABA signaling. This inhibition, intoxication will be disinhibition, euphoria, slurred speech, ataxia, disoriented, drowsiness, peri, orifacial rash. Rapid onset and resolution. The withdrawal will be irritability, dysphoria, sleep disturbance, and headache. Inhalants will be a case of a patient whose teacher found him staggering and falling in the school parking lot. When she found him lethargic, disoriented, slowly improved over the next 30 minutes when he came to the emergency. Alert, blood pressure, on physical examination, abrasions of the right arm and chin, and rash around the nostrils and mouth. This is characteristic of inhalants. Then we go to the stimulants. First, non-specific are mood elevation. So when you cause intoxication by stimulants, we cause mood elevation, decreased appetite, psychomotor agitation, insomnia, cardiac arrhythmia, increased heart rate, and anxiety. Withdrawal will be post-use, will be crash, including depression, lethargy, increased appetite, slow sleep disturbance, vivid nightmares. Amphetamines induces reversible of monoamine transporter, VMAT, DAT, CERT, NET. What is that? Okay, amphetamine induces, this is the mechanism of action. Amphetamine induces reversal of monoamine transporters. Yeah, this is the transporter, VMAT, DAT, CERT, NET. Okay, increase neurotransmitter release. It will cause euphoria, grandiosity, mydriasis, prolonged wakefulness, hyperalertness, hypertension, paranoia, fever, skin excoriation with methamphetamine use, severe cardiac arrest, seizure treatment, benzodiazepines for agitation and seizures. Benzodiazepine for agitation and seizures. Then we will have the withdrawal of amphetamine will cause myth, mites, tactile hallucinations. Psychoactive drug intoxication and withdrawal continued. Caffeine, adenosine receptor antagonist. This is important cause palpitation, agitation, tremor, insomnia. Withdrawal will be headache, difficulty concentrated, flu-like symptoms. Cocaine, blood blocks reuptake by dopamine. That, serotonin, CERT, and norepinephrine net transporter. Okay, so the dopamine is the blocking of reuptake. Impaired judgment, the intoxication will be impaired judgment, mydriasis, diaphoresis, hallucination, including fornication, paranoia, angina, sudden cardiac death. Chronic use may lead to perforated nasal septum. This is very characteristic due to vasoconstriction and resulting in symptom necrosis. Treatment is benzodiazepine for cocaine. Withdrawal will be restless, hunger, severe depression, sleep disturbance. Let's see the question. First one is to emergency, alteration local blood pressure is very high, incompatible, uncooperative, pupils are dilated to active fluoride, inhibition of which of the following process. This patient, cocaine intoxication, inhibit presynaptic reuptake of monoamine, resulting in. Okay. This is another case. 31, assaulted a stranger. You don't understand, I'm the one who needs protection. The Russians are secret. Extra movements are intact, pupils are dilated, speech is loud. Okay, pupils are dilated. Which of the following is cocaine intoxication? Okay. Last question. Patient 28, suicidal. He has no way out. He had thoughts of illness for the past few days. The nursing staff note that he is irritable, withdrawal, hypersomnia, hyper. This patient most likely result of which of the following condition? He appears lethargic, is cocaine withdrawal. People show multiple examinations, multiple heat scars from motorcycles with abnormalities. Refuse to provide an example, refuses recreation drug use, alcohol intoxication. Nicotine, stimulants, central nicotine acetylcholine receptor. stimulate central nicotine receptor. Intoxication will be restless, withdrawal will be irritable, anxiety, restless, decreased concentration, increased appetite, and weight. Treatment nicotine replacement therapy, patch gum lozenge, antipropion, and varenicline. We'll discuss them now. Okay, starting with hallucinogens. First one is lysergic acid dithylamide. Lysergic acid dithylamide 5-HT2A receptor agonist, where perceptual distortion as visual and auditory, depersonalization, anxiety, paranoia, psychosis, flashbacks, mydriasis. Mydriasis is found in the lysergic acid dithylamide and the MDMA ecstasy and the cocaine. So mydriasis is not very characteristic, while the meiosis is found in opioids only. Okay, yeah, it has been pointed as opioid. Lysergic acid, it is 5-HT2A receptor agonist, and it is associated with visual hallucination or distortion. Cannabis cannabinoid. This is a CB1 receptor agonist. It causes euphoria, anxiety, paranoid delusions, perceptions of slow time, impaired judgments, social withdrawal, increased appetite, dry mouth, under fiber injection, hallucinations. When we have the withdrawal, it will cause irritability, anxiety, depression, insomnia, restlessness, and increased appetite. Irritability, anxiety, restlessness, increased appetite. So the difference between the nicotine and cannabinoid is the appetite. After you stop the appetite, you will decrease. If you stop the cannabis, your appetite will decrease. But while nicotine increases appetite. And of course, with the cannabis insomnia, you can't sleep, and nicotine will have low concentration. Euphoria, anxiety, paranoid delusions, perceptions of slow time, impaired judgment, social withdrawal, increased appetite, dry mouth, under fiber injection, hallucination. Okay. So in this in the cannabinoids, the question will be like a teenager started hanging out with his new friends, school friends, whatever, and then he became anxious, euphoric, and he had these symptoms. And he'll ask you like, what else do you expect to see? And the answer would be conjunctival injection. And yeah, this is a question. Let's go to the MDMA ecstasy. This is reversal of transporters for monoamines like serotonin and DAT and NAT, increased neurotransmitter release, euphoria, hallucinations, disinhibition, hyperactivity, increased thirst, distortion, distorted perception, mydriasis, life-threatening effect include hypertension, tachycardia, hypothermia, hyponatremia, serotonin syndrome with MDMA. Depression and fatigue, change in appetite, difficulty concentrating, anxiety. Then we go on to the different cycle. We have like 3 questions here. This is NMDA receptor antagonist. So this is the first question. We ask about a patient who will always come. He's violent. He will have nystagmus. Nystagmus is very, very characteristic in the case. Impulsivity, psychomotor agitation, tachycardia, hypertension also is very characteristic, and analgesia, psychosis, delirium, and seizures. And the patient will present very aggressive. He's having hypertension, nystagmus, and he starts fighting with people, with the police, with his girlfriend. And then when he asks about the incident, he will forget. Alcohol use disorder, diagnosis using criteria for substance use disorder, complication will be vitamin B1 thiamine deficiency, alcoholic cirrhosis, hepatitis, pancreatitis, different neuropathy. This atrophic treatment is natric zone, reduces craving. This is a very characteristic drug. Natric zone reduces craving, avoid liver failure. Acamprosate, contraindicated renal failure, disulfiram, to condition the patient to abstain from alcohol use. Support groups such as Alcoholics Anonymous are helpful in sustaining abstinence and supporting patient and family. Okay. Then Wernicke-Korsakoff syndrome results from vitamin B1 deficiency. Symptoms can be facilitated by administrating dextrose before vitamin B1. So this is glucose. Okay, triad confusion, ophthalmoplegia, and ataxia, encephalopathy, may progress to irreversible memory loss, confabulation, because they make new memories, so they make up stories, personality change, Korsakoff syndrome. Treatment is in IV, vitamin B1 before dextrose. So you have to give vitamin B1 because the dextrose uses vitamin B1 as, so it depletes the dextrose, depletes vitamin B1. So a patient that already has vitamin B1 deficiency, when you give dextrose, the eventual vitamin B1, so he will have the Wernicke-Korsakoff. Starting with pharmacology of psychiatry. First of all, we go through the psychotherapy, behavioral therapy, cognitive behavior, and so on. Behavioral therapy teaches patient how to identify and change maladaptive behaviors, or indicate the actions to stimuli. So it is identify or change maladaptive behavior. Okay, so it teaches patient how to identify and change maladaptive behavior and reaction to stimuli. Systemic desensitization for specific phobia, systemic desensitization for specific phobia. Then we go through the cognitive behavioral therapy, teaches patient to recognize distortion, the thought process, recognize distortion, the thought process, develop constructive coping skills, and increase maladaptive coping behavior, creates emotional control and tolerance of distress, recognizing triggers of alcohol for alcohol consumption. For example, recognizing triggers for alcohol consumption instead of dealing with the triggers in a wrong way of consuming alcohol, they will have more emotional control and tolerance of the distress and develop constructive coping skills to deal with it. Dialectical behavioral therapy, designed for use in borderline personality disorder, but can be used in other psychiatric conditions as well as depression. Interpersonal therapy focuses on improving interpersonal relationships and communication skills. So the interpersonal therapy is the interpersonal relationships and communication skills. Then we go to the motivation and interviewing, enhances intrinsic motivation to change by exploring and resolving ambivalence used in substance use disorder weight loss. Supportive therapy utilizes empathy to help individuals during a time of hardship to maintain optimism and hope. Supportive therapy, wow. Then we'll go to the central nervous system stimulants.